So moving on to question number three about neoadjuvant therapy, and it's a really hot topic, again, across all of oncology. A lot of interesting studies that are coming in anaplastic thyroid cancer. So for the panelists, what are your thoughts? And I'll ask Dr. Cubb first, just for the patients to define what neoadjuvant therapy is, and then let you guys kind of tell me what you're thinking about this area of research for anaplastic.
Yeah, so neoadjuvant therapy is the idea of going on a treatment prior to undergoing surgery. So it's what we do before surgery in order to enable surgery in a lot of aspects. As Dr. Blumberg had brought up, he only wants to operate on these people if he knows he can get this tumor out. And that would make a difference. For instance, we've stepped away from just operating on the neck if we know there's a lot of disease in, the lungs, the liver, other places, because again, it sounds scary to say we're not going to operate there, but the reason that is because we want to make sure we're treating the other disease. And sometimes if we operate, we actually delay treatment in other areas. So again, that decision is really complex. But the idea of neoadjuvant therapy is that we can get more of our patients to surgery. Again, it's a hot topic, but we already have studies that show we can improve survival and have patients live longer. And again, stepping away for doom or gloom, before this was a diagnosis with a median overall survival of mainly 5 months, we now have patients that are 5 years out, 9 years out, 10 years out. Our goal is to be able to continue to move this research forward so we can continue to have more of that and even possible cures with time. Something that wouldn't have even been discussed 10 years ago. And, doing things like neoadjuvant therapy, these are the next steps in therapy.
I love that perpetual optimism, Dr. Cubb. Dr. Blumberg, what do you think?
Yeah, I mean, I think this is a fascinating and really exciting area of medicine. It's rare that in your career you see things shift so dramatically in terms of survival for cancer. So it's really exciting, for us as clinicians, but also really important for patients. Yeah, so I think, there's 2 points to neoadjuvant, like Dr. Cubb alluded to. One is, trying to get this to the point where it's quote unquote resectable, meaning we can get it out in a reasonable manner. And we also know that some of these systemic therapies can help with overall survival by, priming the immune system or things like that. Questions for Dr. Cubb or Dr. Sheth, who are much smarter than I am. But I think it's exciting. I think that, what we've seen in BRAF mutated tumors, I hope is going to be translatable to the BRAF wild type tumors using different tyrosine kinase inhibitors or these drugs that we use to treat these cancers and hopefully get all of people who have thyroid cancer, regardless of their mutation, into the survival curves that we see with the BRAF mutated.
That's great. And Dr. Johnson, I'll just ask you too, when you have a patient and you're seeing more patients who have been receiving neoadjuvant therapy, are you able to tell it different from a surgical pathology standpoint?
Yeah, so very very frequently we will see changes to the tumor under the microscope, or we see the tumor has melted away. In many cases, I haven't seen too many cases of anaplastic thyroid carcinoma, but right, it's being frequently used in other head and neck cancers. And it definitely is changing how the tumor looks under the microscope. And again, as Dr. Blumberg said, kind of priming the immune system, recruitment of immune cells to the area, and then leaving behind just kind of signs that the tumor was there under the microscope.